Good afternoon. I'm here with Brave. I have Dayna Murphy, Executive Director to Brave, Christine Grogan, founder. Most importantly, we have Dr. Emily Kirby. She's in Houston. She's the Chief of Plastic Surgery at Texas Health Methodist Hospital. Not only is she chief there, she has a fellowship in craniofacial surgery at the Craniofacial Foundation in Salt Lake City. And that is a mouthful, Dr. Kirby.
It is, isn't it?
I met Dr. Kirby about 2 years ago at the Texas Society of Plastic Surgery, and it's so nice to have you on air today. I'm going to hand it over to Dayna and Dr. Kirby to talk about nipple sparing techniques. Most recently, we had a patient come to us that asked us why her surgeon was going to cut off her nipples, and she was really worried about it, and we referred her on to somebody else. And fortunately, they saved her nipples because that was important. So, Dayna, Dr. Kirby, thank you.
Thank you.
Thank you
for the intro. So kind of to piggyback back off of what Christine said, we've been really out in the community asking patients, different questions that they've had in hindsight. What do you wish you would have known, back then, or what do you wish you would have asked? And so one of the things that I've heard over and over is about nipple reconstruction, the different options behind it. And they weren't really aware of, the different things that could have happened. So I'm so grateful for you to be able to jump on and kind of talk through this for the patients out there. So I'm just going to jump right into the different questions that I have written down.
Sure.
Okay. So, one of the things, obviously one of the patients was asking, I didn't have any idea of any of the different types of nipple reconstructions there were. So can you walk us through the different options that they have?
Sure, absolutely. I think the one that I think astounds most people is the actual surgical reconstruction of the nipple. And it was, just as a side note, it was one of the things that I first saw as a student that blew me away. And I thought it was one of the coolest things ever. And so basically what you're looking at is taking tissue that's there on the breast after the mastectomy, after the reconstruction, and it's kind of the last thing that you do in order to reconstruct an entire breast. And so you take the tissue that's there, and there are lots of different techniques, but we call it a local flap reconstruction, where we take the tissue, rearrange it, remodel it, fold it on itself, and make a standing nipple.
Wow.
We'll do that in combination with a skin graft, or you can also do it without a skin graft. My technique that I use, I take some skin from the groin area, which is naturally a darker pigmentation. And I put the skin graft around as that circle, as the areola, which is the pigmented part around the nipple. And so that way you don't necessarily have to tattoo it later. And we'll get to that in a second, but the naturally darker pigmented tissue can look more like a natural areola, that's that surrounding tissue. And so we wait for that tissue to heal. A lot of times you lose a little bit of the projection, a little bit of the stick-upness of the reconstructed nipple, and it will settle over time. After that, you can actually tattoo the reconstructed nipple, or you can opt for a completely different approach, which is not surgical, and that's just a simple 3D tattoo to make it look like you have a pigmented nipple and a pigmented areola. And that's done using certain techniques that as you look at the skin, it's meant to look like a 3D nipple there, but you don't actually have any tissue that's sticking out.
Hey, Dr. Kirby, I have one question. Is it reimbursed if you do it the way you mentioned from the groin area, or if you go out and do a certified tattoo artist? Is it reimbursed both ways?
It's a very good question. It's been difficult over the years to get it reimbursed. What most plastic surgeons do, but first of all, surgically, it's almost always reimbursed. And of course, it depends on your specific plan, your specific policy, but most of the time, the codes that we use are reimbursed in order to do the surgical reconstruction. If you then tattoo the surgical reconstruction, or if you opt for just the tattooing, that is harder to get reimbursed. Medicare sets a lot of the rules that other major medical insurances follow. And so historically, it's been very difficult to get that reimbursed. But what we usually do is invite the tattoo artist, the professional tattoo artist, into our office, and it's then billed on our behalf as a surgical visit, and then we pay the tattoo artist ourselves. So it's not necessarily reimbursed as a procedure, but just the visit itself.
That's great information, Dayna. I'm sure that's the questions that comes up from your patients.
Yes. Yeah. I mean, that's, obviously the cost of everything is something that's a concern. Thank you for answering that. That was very interesting.
Sure.
How do patients know which is the best option to choose for them? How do you walk through the different options with the patient and then help guide them to make, the best decision?
It's very variable, and I have to say that every patient is truly unique based on the history of surgery that they've had, based on the history of scars that they've had, the scar patterns, the scar locations that they have, the thickness of the tissue, the thinness of the tissue, if somebody had radiation. All of that goes into our recommendations and our discussions that we have with the patient. So, for example, somebody who has had radiation is not going to heal as well. And especially if that's combined with somebody who's had radiation who has thinner tissues over, say, an implant, we're going to worry a lot more about possibly risking exposure of the implant in doing a nipple reconstruction. And so we have to take that into consideration. So sometimes I have a patient who we just operated on right before the whole COVID shutdown and pandemic and everything. But we did fat grafting because she has had radiation. We did fat grafting in order to thicken the tissues, to give it time to give us a little more bulk to work with, because she very much wants a surgical nipple reconstruction. And so in planning to do that, we're probably going to have to do one more round of fat grafting over the implant, between the skin and the implant, in order to get enough thickness so that we can safely approach that nipple reconstruction without worrying about exposing the implant. Because if we expose the implant, we're in trouble, and that implant may have to be removed.
Fascinating. I'm learning. So this is all amazing information for me to have too. What I'm hearing you say is it's a process, right? Like it takes some time, different, steps that you have to take. How long do you think the whole process is? That I'm assuming that depends on the person as well.
For sure. It very much depends on the person. It depends on the patient's goals. It depends on, some people want one and done. And I think we all would love to have one and done with the best looking breasts ever, but that's not always possible. And so much, again, goes into that decision making, such as your weight, your medical comorbidities, basically what other medications do you take for what medical conditions. We want to know all of that going into it, because we don't want to recommend a course of multiple surgeries that might put you at risk because of other issues that we have. So as appealing as it is to try to do a one and done breast reconstruction, I have to say that's almost never possible. But on the other hand, I have a couple of patients who only wanted a breast mound. They didn't want any finessing of the breast, any very specific contouring of the breast. They were not interested in a nipple. And I have a few patients who had a nipple-sparing mastectomy, straight to implant, with no additional procedures. It is pretty rare to get that, but a lot of people end up finding themselves in a situation where they're actually asking for more because they want an improved contour. They want a more natural looking breast. They want that final step of adding the nipple and the pigmented nipple so that it looks and feels more natural. So it really depends so much on what somebody wants.
I love it. Thank you. Okay, so the other question that kind of went alongside of all of this, that one patient said, I really wasn't expecting this. I had no knowledge of what was going to come. And I wish I would have, so I could have asked these questions, when it was happening. The nipple sensation, she said she has absolutely no, sensation. How do you prepare for it? And how can you help women through this surgery like regain their confidence with their sexuality, is what she was saying.
It broke up just a little bit, so I'm not sure I heard all of that, but I think you were asking about preparing a patient to know what's going to come and to be prepared for losing sensation in the nipples. And that's been, it's been an ongoing discussion that we have between the plastic surgeon, which is myself, and the surgical oncologist. You know, if you think about very briefly where we started with initial mastectomies, they were taking the entire breast and all of the muscle, and it was very disfiguring. And of course, the goal has to remain to remove the cancer. That's the most important part of everything. It's important to remember that. But along the way, we've discovered that we can do nipple sparing mastectomies. We can do breast conserving therapies. We do breast reductions combined with lumpectomies. And we're very much more recently focusing on keeping a feminine figure, keeping a female breast, which is so important to how you look and feel later. And then most importantly, how you feel later as a woman in your clothes, wearing the bra, functionally not having a bra that pulls to the side all the time because you've got one side that's not the same size as the other. And so we've focused now more on the sensation of the patient and the after effects and how we're going to feel with that. And so it's been a very, very much of a shift in letting people know, hey, this is a very realistic outcome. And so we've talked a lot more with the oncologists, with the breast surgeons on making sure that we let people know how that's going to feel later. And it's become a lot more important to the breast surgeon now, besides being important to us, because again, they've been focused on removing the cancer, but now they're very much more focused on the effects on the patient and how it's going to feel, how it's going to look, and all of that. And so it's been a shift in the discussion. So that being said, the vast majority of nipple sparing patients were preserving the nipple, but a higher percentage, more than 50% of the patients will lose sensation in the nipple. Very, very few patients retain sensation. And that partly has to do with how big the cancer is, how far it is away from the nipple, how much nipple tissue they have to remove in order to comfortably know and feel secure that we have removed the danger to the patient. And so it's very individualized, but it has to be part of that discussion that we have going forward, knowing what to expect. They're dabbling with great surgeries now where they're actually retaining the nerve and trying to hook up that nerve and giving people sensation in the breast. And it's not the same as the breast that we had. It's not the same as the nipple sensation that we had, but to have sensation at all is a huge step in the right direction. And I think, you know, it's continually evolving, and we're trying to keep up with giving patients the education that they need and they deserve.
I think that's great, Dr. Kirby. I think we should do another series on this around that new technique, because I know Axogen's one of the companies I've been following that has that technique, and I don't know much about it at all, but I think it'd be good to educate women on those type of questions to ask and how they can make sure the sensation at least tries to remain there, if not at all, you know, possible. One thing that you said, I think we should close on, that Brave is all about, and that is getting what you said, that oncologist, the breast surgeon, everybody together as a team, which sounds like at your center, it's a really nice team approach to make sure that, sorry, dogs. Just, it's so fun working with phone now. I don't know how newscasters do it, but anyways, the team approach, I think will end with that. Crazy.
For sure. It's definitely a team approach.
Thank you. All right. Well, thank you. There were some glitches today. I think everybody is on Zoom and these other type of platforms. This is StreamYard, but it kept freezing up. Yeah. So I apologize for our viewers, but we'll send this out and replay it. And Dr. Kirby will tag you in it. So if anyone has any questions, and thank you, Dr. Kirby and Dayna, great job. And we'll be back.
Sounds good. Thank you.
Thank you. Have a great day.
Bye.
Thank you.
Bye-bye.